So the CARD study was a trial that looked at compared cabazitaxel to next generation anti-androgen therapy in men with castration-resistant prostate cancer. Sequencing is a complex issue in the treatment of men with castrate-resistant disease, and the CARD study was really one of the first trials to help answer this question. Castrate-resistant prostate cancer patients who had progressed on either abiraterone or enzalutamide, as well as docetaxel, were randomized to receive either cabazitaxel or the alternative anti-androgen. So if they received enzalutamide, they received abiraterone in the study. If they initially received abiraterone, they received enzalutamide in the study. Patients had to have progressed within 1 year on abiraterone or enzalutamide as their first next generation anti-androgen treatment. The CARD trial demonstrated a progression-free, or radiographic progression-free, as well as overall survival difference or benefit in favor of cabazitaxel compared to the alternative anti-androgen. So what Dr. Tomball did was he further analyzed this data in terms of prognostic factors, in terms of other factors that may have influenced the overall outcome. Because again, this was a small randomized phase 2, and small differences in patient populations could have actually accounted in part for the survival benefit and the radiographic progression-free survival benefit. So what he looked at was the metastatic disease at the diagnosis, whether they had metastatic disease at diagnosis or whether they were localized and then went to develop metastatic disease, visceral metastases, Gleason score, prior therapy with curative intent, and type of progression. Other covariates that were looked at were included hemoglobin, lactic dehydrogenase, visceral metastases, the Gleason score, the alkaline phosphatase, and the PSAs, and these were also looked in terms of the absolute value in log of 10. And a significance level of 0.1 in this multivariate analysis was used as a way to determine whether these variables were significant. What fell out in this analysis was treatment with cabazitaxel is the most significant with a hazard ratio of 0.628, followed by neutrophil to lymphocyte ratio, hemoglobin, as well as PSA. So again, cabazitaxel treatment seems to trump these prognostic factors in terms of our patients. They also looked at a variety of different variables in terms of overall survival from the development of metastatic disease to the time of from castrate resistance to the time that they go on study. Again, there was no there was a survival benefit in favor of cabazitaxel. What this analysis does is it helps to weed out those patients who may be slower progressors. And then overall survival from the time of the second LET initiation, OS, again, it was in favor of cabazitaxel in this situation. So the authors concluded that the data was robust and that cabazitaxel was a reasonable option in those patients who failed docetaxel as well as an anti-androgen within 12 months. Practical implications are that again, we have a way to sequence our patients with castrate-resistant disease. And we didn't really have good guidance. In fact, what was used before was quality of life issues. People argued that because somebody was being treated with a next generation agent sequentially, we all know that these responses are not necessarily the best in a sequential fashion. In other words, abiraterone after enzalutamide or enzalutamide after abiraterone usually has a lower response rate and a short duration response if they do respond. That the tendency was to put patients on oral agents because it was easier and better tolerated. I think here the survival benefit does seem to cancel out any effect that may have. So one of the major questions that is involved in the CARD trial is the types of toxicities that you would expect to see, and is there a difference in older patients versus younger patients? So Cora Sternberg actually analyzed the CARD data based upon age and basically split the group up into patients either less than 70 years of age or greater than or equal to 70 years of age. And I think the interesting thing that was noted was that any grade 3 or grade 4 AE was similar. It's about a 6% difference in favor of hiring in cabazitaxel in those younger than 70, and it's about 8% in those greater than 70. So it doesn't seem to be that much of a difference between the two. But what I think was really striking was that the patients who received these next generation antiandrogens, they had a 9% rate of grade 3 or higher AEs, compared to 0 in the cabazitaxel arm for age 70 or older. And it was 1.6 versus 0% in those who are less than 70. So I think that that's an interesting trend. We know that drugs like abiraterone are now associated with higher rates of cardiac events. And in fact, what is not surprising about this data was that there was a 3% rate of febrile neutropenia, and it was consistent as to whether these patients were less than 70 or greater than 70. So in summary, there is a different adverse event pattern, and the adverse events are different in those who are treated with cabazitaxel, predominantly neutropenia, versus cardiac disorders in those patients who are over 70 who were treated with the next generation antiandrogens.